Hello students, I am Dr. Indra Priyadharshini, Associate Professor and Department of Oral Pathology, Vinayaka Mission Shankaracharya Dental College, Salem. So today I will be talking about epithelial pathology and oral submucous fibrosis. Today we are going to see oral submucous fibrosis is commonly abbreviated as OSMF. This is one of the most common oral potential malignant disorders that every dental students must understand because it is frequently encountered in clinical practice and especially in India. The disease causes progressive fibrosis of oral mucosa and leading to burning sensation and reduced mouth opening and difficulty in eating, speaking and swallowing. Most importantly, the patient with OSMF have increased developing of oral submucous fibrosis along with oral squamous cell carcinoma. During my lecture, we will be discussing etiology, pathogenesis, clinical features and histopathology and classification and treatment. So these are my contents. We'll be highlighting about the history, definition, epidemiology and etiology and clinical features, classification, histopathology and malignant potential and the treatment plan. So learning outcome of this, you will be knowing about definition of oral submucous fibrosis, describing the epidemiology and explaining about the etiopathogenesis and clinical features and histopathology, and we will be discussing about the molecular pathogenesis and also the treatment plan. So coming to the history of oral submucous fibrosis, it is not a newly recognized disease. In ancient Indian medicine, the sutras describe the similar condition called Vedatri, where the patient experienced burning sensation and pain and inability to open the mouth. The disease encountered in literature in 1952. When Squats described it's among the Indian women living in Kenya, the named as a atrophic idiopathic mucosa oris. So 1 year later, in 1953, Joshi has renamed his as a submucous fibrosis, which eventually become oral submucous fibrosis. Today, it is recognized worldwide. It is a potential malignant disorders. So coming to the definition of oral submucous fibrosis, this definition is worldwide accepted definition was given by the Pinberg and Schwartz in 1966. So according to them, oral submucous fibrosis, the incidence chronic disease that involving the oral cavity and sometimes the pharynx. So the disease begins with a chronic inflammatory beneath the epithelium. So the collagen becomes thick and dense and producing the fibrosis. At the fibrosis process, the mucosa becomes ridged and loses the elasticity. So the patient will be having a difficulty in mouth opening. The results in reduced mouth opening is known as a trismus. So the patient also complaining of burning sensation while eating spicy foods. Eventually they experience difficulty in speaking, chewing and swallowing. So remember one important point for examination, oral submucous fibrosis is a chronic inflammatory disease characterized by the progressive fibrosis resulting in stiffness of the oral mucosa. Coming to the epidemiology, oral submucous fibrosis occurs in Asian countries. India has the highest prevalence because of the widespread habit of chewing areca nut. So it is commonly seen in India, the Sri Lankan or Pakistani or Bangladesh and Taiwan, they will be having a habit of chewing areca nuts. Previously the disease is most observing among adults, especially the age group of 30 to 50 years. Nowadays it is increasing affecting the teenagers and young adults because the commercial available of the products in India. It will be available in the name of gukka and pan masala and sweet subari and flavored areca nut are easily available in the markets. So both the males and females can develop this disease. The incidence is steadily increasing due to easy accessibility of the packet areca nut products. So this is the main epidemiology in India. Coming to the etiology, the OSMF, it is a multifactorial etiology, mainly the local factors. The single most important cause is areca nut chewing, and other countries, the contributing the factors and also includes chronic consumption of spicy chilies and nutritional deficiency, particularly the deficiency of iron, vitamins and proteins. And also some cases reported with genetic susceptibility and autoimmune mechanism or repeated trauma from chewing habits. So although the several contributes like areca nut that remains the principal etiological agents, therefore the habit of history is extremely important while examining the patients. Coming to the pathogenesis, now let us understand how the fibrosis develops. Normally the collagen synthesis or collagen degradation remain balanced, and in OSMF this balance is disturbed. The areca nut stimulates the fibroblast. The fibroblasts produce the excessive collagen. At the same time, the collagen degradation decreases because of collagenase activity become reduced. So the inflammatory cells that start releasing the cytokines like TGF beta, whether the further stimulate fibrosis. So the lysyl oxidase activate and increases cross-linking of collagen increases. As a result of collagen becomes resistant to degradation. So eventually thick fibrosis bands develops and beneath the oral mucosa. These bands are reduced elasticity and can restricted mouth opening. Coming to the most important etiology, that is chilies, that is capsaicin. This is the most active component present in chilies. It acts as a chronic mucosal irritant. So the patient complains of burning sensation while eating a spicy food. So the long-term irritation causes epithelial changes and chronic inflammations. So however, the chilies also do not cause oral submucous fibrosis. This mainly aggravates the fibrosis in patients who already chew areca nut. So coming to the main important factors, this is the main important etiological factors of oral submucous fibrosis, that is areca nut. Areca nut, it also contains arecolin, arecadine, coaginin. So among this, arecolin is the most active agents. So the arecolin that stimulates the fibroblast proliferation and fibroblast synthesis the excessive collagen. Hydrolysis converts the arecolin into the arecadine, which further promotes the fibrosis. So the excessive collagen accumulates, ultimately cause trismus, a difficulty in mouth opening. Therefore, wherever you diagnose oral submucous fibrosis, always ask the patient about the areca nut chewing. You ask the patient when you are taking a history, you have to ask the patient about how long you are taking these habits. Okay, so coming to the collagen stabilization, the areca nuts also contain tannins and copper. Therefore, the collagen cannot be degraded efficiently. The copper that increase the lysyl oxidase activity. The lysyl oxidase strengthens the collagen fibers by increasing the cross-linking. So the collagen becomes very thin, thicker and stronger and more resistant to breakdown. This explains why fibrosis progresses continuously. So this areca nut contains the tannins and coppers that plays a major role in fibrosis. Coming to the clinical features, the onset of clinical features, it's developed gradually over the several years. So the initial patient complaints is burning sensation while eating the spicy food. This may notice recurrent ulcers or vesicles or dry mouth are most common of oral submucosis patients. As the fibrosis progresses, the blanching of oral mucosa that appears. The mucosa loses the elasticity and vertical fibrosis bands become palpable. When you are palpating the patient, you are able to see the vertical fibrosis bands. So the mucosa is the most commonly affected size when the patient chewing habit is more prolonged. So the mucosa has become affected size. So the retromolar regions, the soft palate and lips may also be involved. It's depending upon the areca nut chewers where they are keeping the pouch. So the retromolar regions, soft palate and lips may also be involved when they are habit of keeping there in the retromolar area or the soft palate. The patient gradually developed restricted mouth opening and speech become very difficult, and the tongue movements is restricted and uvula has become shrunken, the soft palate movement is decreases. So, and also you are able to see when you examine the patient clinically, you are able to see the shrunken uvula and the soft palate movements that decreases and loss of stippling occurs. The patients may also develop referred pain because of the fibrosis that extends to the surrounding muscles. Here I will be showing the photograph. Here you are able to see the fibrosis that extends to the surrounding mucosa. So this photographs that shows the demonstrating of the blanching, the fibrosis, bands, and you can see the severe trismus, difficulty in mouth opening of the patients because of the habits, chronic habit. The one image shows the carcinoma that develops in oral submucous fibrosis, and also you can see the malignant potential of the disease. Coming to the different types of oral submucous fibrosis, there are two different types. One is a yearly oral submucous fibrosis. The yearly symptoms, the burning sensation in the mouth when they are consuming the spicy food and appearing the blisters, and especially on the palate or ulceration or recurrent generalized inflammation of the oral mucosa or excessive salivation or difficulty in gustatory sensation and dryness of the mouth. These are the yearly symptoms of oral submucous fibrosis patient. And also most of the advanced cases, as the disease progresses, the oral mucosa becomes blanched, stiff, and they becomes very trismus. So these are the other features when you are encountering of oral submucous fibrosis patients. The patient will be having a difficulty in deglutition and referred pain in the ear, and also the patient feel the deafness and nostril innovation of voices. They are able to speak, and depapillation of tongue and restricted movements of the soft palate and bird-like shrunken uvula and loss of stippling. So these are the main common features when you are encountering oral submucous fibrosis patient. So this is the example of blanching over the left buccal mucosa and decreased mouth opening, and the last picture shows the soft palate and facial pilus showing the redness, and shrunken uvula also you are able to appreciate. So coming to the classification, there are several classifications that exists over the pathological books and journals, and these are the very important clinical finding. Based on the clinical finding, the Penberg gave a classification of stage 1, stage 2 and stage 3. The stage 1, the stomatitis, that is erythematous mucosa, vesicles and ulcers and pectic. So stage 1, they will be having the inflammation. There will be the erythematous mucosa and vesicle formation, ulceration and pectic. And stage 3, you are able to appreciate the fibrosis in healing, vesicles and ulcers and blanching and palpable bands. When you are examine the patient, you are able to appreciate the palpable bands and motile marble like appearance. And stage 3, sequelae of oral submucous fibrosis, you are able to appreciate the leukoplakic patches, and speech and even hearing difficulty will be you are able to appreciate in the stage 3 level. So based on the interincisal distance, so here the group, they are having 30 mm, more than 30 mm they are considering the incisal distance, interincisal distance. The group 1 and group 2 between 30 and 35, group 3 between 20 and 30, and group 4 between less than 20, they will be considered as a 20, group 4. And idarism in 2000 they have given a classification on the based upon the clinical staging and functioning. And clinical staging, the stage 1 they will be having a fascial bands, and stage 2 the fascial bands and buccal bands, and stage 3 the fascial, buccal and labial bands if you are able to appreciate while palpable bands are present in clinically. The functional staging, it depends upon the mouth opening. 20, it's greater than 20 mm that considered to be the grade 1. Grade 2 is 11 to 19 mm, and mouth opening less than 10 mm they consider to be the stage 3. So these are the different types of morphological variants of the soft palate. So morphological variants of the soft palate depends upon the shaped that appears on the soft palate. The type 1, that is the leaf shaped, type 2 that is a rat tail shaped, and type 3 it's a butt shaped, and type 4 is a straight line, and type 5 is a deformed S, and type 6 is a crooked shape. So this depends upon the morphological variants of the soft palate appearance. Coming to the histopathology, and histopathology you are able to appreciate the classic oral submucous fibrosis picture here, and showing a very thin atrophic epithelium and chronic inflammatory cells and dense fibrosis in the submucosa. Here you can see the thin atrophic epithelium, and here you can see the fibrosis in the connective tissue. So microscopically the early lesion shows very atrophic epithelium, very minimal hyperplasia will be seen. There are inflammatory cell infiltrate beneath the epithelium, and fibroblasts remain very active. The collagens are very thin. At the disease progress, the collagen becomes very thicker and they undergo the hyalinization, and you are able to appreciate the subepithelial hyalinization here. You can see the subepithelial hyalinization just beneath the epithelium. So this is just a epithelial hyalinization. So here you can see the underlying epithelium, it's undergo the hyalinization, and blood vessels becomes narrowed, and fibroblast that decreases, the epithelium become very thin and atrophic. So the retiridges appears very flat. The muscle fibers undergo the degeneration, and if you want you can able to see in Van Gieson or stains highlight the dense collagen fibers. It is given in the pictures in many atlas. And histologically oral submucous fibrosis, it's divided into very early stage and moderately advanced and advanced stage. So the grading, it's also exhibits the progression of epithelial, it depends on the epithelial hyalinization and epithelial hyperplasia to severe epithelial atrophy with dense hyalinized collagen. So remember students, so the early stage, the inflammation and active fibroblast will be present. When it is a later stage, which is an advanced stage, the epitheliums become very atrophic and dense hyalinized collagen fibers and epithelial atrophy will be present. So on the basis of histopathological appearance, the HND, the presence of presence or absence of edema will be present, and physical trace of mucosal collagen bundles, and overall the fibroblastic response, the number of cells and ages of individual cells. So the state of the blood vessels and predominant cell type, that inflammatory exudate will be present. It depends upon the types, very early and moderately and advanced stages. So coming to the histopathology, the epithelial changes, it difference the stages of oral submucous fibrosis. It's predominantly the hyperplasia. Hyperplasia you are able to find only in the early stages, and atrophy you are able to find in the advanced stages. It is associated with increased keratinized metaplasia, that is shortened and flattened retiridges. And also the Pinbach as 1966 is marked the epithelial changes in advanced oral submucous fibrosis cases, which contrast with predominantly hyperplastic epithelium of early oral squamous cell carcinoma. And also in few cases, the advanced cases, there is buccal mucosa. More commonly, there is parakeratosis and high mitotic content in parakeratotic epithelium, which more in oral submucous fibrosis associated with leukoplakia. And also you are able to appreciate the atrophic epithelial changes that predispose the oral submucous fibrosis to malignancy. So this is the classic picture of oral submucous fibrosis. Here you can see the atrophic epithelium without retiridges. You can see very flat retiridges, and here you can see the just beneath the epithelium you are able to appreciate the juxta epithelial hyalinization. Just beneath the epithelium there is a hyaline line, that is called juxta epithelial hyalinization, and below the connective tissue you are able to appreciate the dense bundles of collagen fibers in the connective tissue, and below you are able to appreciate the muscle fibers that showing the degeneration. So this is the picture the given in Maji Jose. This is the schematic diagrammatic pictures. You can see, you can easily refer atrophic epithelium, juxta epithelial hyalinization, and dense bundles of collagen fibers in the connective tissue, and muscle fibers that showing a degenerations. So these are the point I am recollecting one by one, because these are the points are very important. The atrophic epithelium, juxta epithelial hyalinization, and dense fibrous connective tissue. So these are the pictures. Here you can see the mucosal biopsy that exhibiting the hyperkeratosis and basal cell hyperplasia and fibrosis in the lamina propria. And this is a second picture that shows the early oral submucous fibrosis with sparing of lamina propria fibrosis, that the stain of Van Giessen stain I told you. This is a picture of Van Giessen stain. Here you can see the lamina propria that shows the fibrosis. This is a special stain that used for oral submucous fibrosis. And this is the last one, this is the advanced stage of fibrosis. Advanced stage of fibrosis in the lamina propria, and this also the special stain of Van Giessen stain. So this is the histopathological grading. The histopathological grading, the grade 1, that is the early oral submucous fibrosis cases. I told you already there will be the hyperplasia and the hyperkeratosis in the epithelium, and you can see the intracellular edema and little basal cell hyperplasia, and retiridge will be present. And grade 3, the epithelium that undergo the atrophy and retiridges is less prominent, and the connective tissue that's showing a thickened collagen bundles and less cellularity and fibrosed blood vessels with moderate amount of hyalinization. And grade 3, that marked atrophic epithelium. You cannot find the retiridges. You can see very thin atrophic epithelium and absence of retiridges, and connective tissue that shows the abundant hyalinization, and you can see the more fibrosis in the lamina propria, and you can see the cellularity absent in the connective tissue. So coming to the treatment part, the treatment, the restricted habits. So you have to ask the patient to restrict the habit, stop the habit, quit the habit immediately, because the reduction and elimination of the habits of areca nut chewing is a more important preventive measures. So when the patient comes with oral submucous fibrosis, first you have to instruct the patient to reduce or eliminate the habits. Without stopping the habits, the treatment will fail, definitely fail. And the next treatment is corticosteroids. Corticosteroids, the medical management includes the corticosteroids injection to reduce the inflammations. So hyaluronidase break down the hyaluronic acid and improves the tissue flexibility. So the placental extract that have been used. See here you can see the nutritional supplements support that includes iron, proteins and vitamins. And the physiotherapy is more plays an important role for the trismus treatment. When the patients with treatment of trismus, the patient you have to suggest with the physiotherapist with mouth opening exercises that improves the function of mouth opening. The patient with severe symptoms, may require the surgical excision of fibrotic bands and followed by the reconstruction and physiotherapy. So these are the basic treatment. If the habit is very early stage, you can ask the patient to eliminate the habits, and if it is very severe, very advanced stage, you can suggest the corticosteroids and hyaluronidase injections, and you can suggest them the treatment of mouth opening. You can give the treatment of physiotherapists and exercises. Coming to the potential, malignant potential. The OSMF is classified as a oral potential malignant disorder. Approximately 7 to 13% may develop oral squamous cell carcinoma. The risk increased when oral submucous fibrosis is associated with leukoplakia or epithelial dysplasia, the continued tobacco habits or areca habits. Therefore, every oral submucous fibrosis patients undergo the regular follow-up. The early detection of oral submucous fibrosis or malignant transformation that improves the survival of the patients. So these are the reference that is taken from the standard textbook, and you can refer Schaefer's and Neville for referring the classification and other details and histopathology and all these things. So thank you for kind attention. So I hope this lecture will be helped to understand the oral submucous fibrosis, that including the etiology, pathogenesis and clinical features and histopathology and management of oral submucous fibrosis. Thank you. Thank you all.